Hello, thank you for joining us today for a discussion with Brittni McGill, Chief Operating and Chief Nursing Officer, to learn how Norman Regional Health System made the change from an outsourced to an in-house dialysis model. Reminder that you can pop in questions throughout today's webinar and we'll have a live Q&A at the end. Over to you, Dr. Aragon.
Hi, welcome everybody. Thank you for joining us. Really excited today to talk to Brittni McGill, COO and CNO at Norman Regional Health System. My name is Michael Aragon. I'm the Chief Medical Officer for Outset Medical. Brittni, thank you so much for joining us today. Really appreciate the time. I know how busy you are.
My pleasure. I'm happy to share our story, and my goal today is really to just answer as many questions as you have, so that we can take better care of patients across the country together.
Great. Well, thank you so much. Maybe probably a good place to start would be just if you could provide a little bit of your background.
Sure. So I have been a nurse for the past 18 years. I have been in the CNO role for the past 8 and then picked up the COO over the last year. And so I've got responsibility over lots of different clinical and operational areas. I'm located in Norman, Oklahoma, which is just on the southern border of the metro Oklahoma City space. And so we receive a lot of patients from southern rural Oklahoma. We're located off of the main I-35 highway. And so as you imagine, it's a great catchment area. And so kidney disease is on the rise. And I think this topic is quite applicable. And you'll see in our results why we did what we did and what we've been able to produce.
Great. Thank you. And could you tell us a little bit about the facility, kind of a little bit about the size of the facility, number of treatments, and maybe kind of set the stage for where the facility was prior to looking into your dialysis services and kind of how that model was working previously?
Sure. So we have one 350-bed acute care hospital, 2 freestanding emergency departments, a 48-bed joint venture behavioral health hospital, and then we've got about 48 different outpatient and ambulatory settings and clinic spaces. And we were at a place where we had a very unreliable contracted service. And because of that, our nephrologists were having to make care decisions, knowing that they may not have the response time needed for patient care. We also found ourselves having to transfer patients out of the health system and really weren't able to provide the level of care that we wanted to. And so that's what pushed us in this direction. And we have actually just closed the books on our first year of insourcing, and we have had a 279% volume increase. And I'll get into how we've done that a little later, but it's been wildly successful.
I'm sure for many people, it's frightening to think of a 279% volume increase in 1 year and how you would handle that. So yeah, I look forward to hearing more about that. Okay, so you're not totally satisfied, we'll say, with your third-party outsourced provider, and maybe the quality, and obviously your physicians are having to think more than just patient care and the quality there as they're starting to try to prescribe and manage some complex patients. So you're looking to make a change. Maybe talk a little bit about why insourcing versus just find another third-party outsourced provider, or kind of how that decision was made.
Sure. So in my 8 years in this role, we had worked with both contracted services that are available in this market. And so we knew what our options were in that space. I had been watching from afar the Tablo device and the Outset Medical vendor for quite some time. And it got to a place that you're right, we were not satisfied. And so we had some pitch presentations. We started to collaboratively put a business plan and a projected ROI together. And then we had what I would call one of the most unsuccessful weekends in our dialysis service. And we went ahead and pulled the trigger early. We had this, nice 6-month plan, and we were progressing through that. We were at about month number 4, and we just said, you know what, we are far enough along. there may be some bumps, but we can't continue like this anymore. We will figure the rest out later. And so in that plan and along that journey, we took a little bit of a different approach. One that I think the Outset team was kind of shocked with our innovation here, but instead of going after dialysis trained nurses, we took the opportunity to grow our own. We had some ICU nurses that had been dealing with that service and had experienced it in such a way that they wanted to step up and they wanted to help. And so this was kind of their idea, and we helped support it, and then we built it from the ground up together. So our team is 90% ICU trained nurses, and at the 1 year mark, we have had a 100% retention rate.
Oh, that is fantastic. How much did Tablo itself play a role in either the decision to insource, or I'm assuming you looked at other technologies and, as you're looking at insourcing, looking at your different options, what was it maybe about the technology, or did the technology made insourcing suddenly sound feasible when it might have been before? So just curious about the device itself and how it led to your decision.
Sure. So doing something like this takes guts. It's a pretty bold move, and you've got to have a lot of faith in that, and you've got to have good partners. And so between those ICU nurses, our nephrologists, and then the Outset medical team, we really became confident in our decision with the Tablo device because we had those ICU nurses looking at it. We had them putting their hands on it, going, to those trainings and demos. And it was very easy to use. It was very portable to move. And so, yes, we have a dialysis unit, but we can also take the device to the bedside. There was no need for a water room. Cleaning was very helpful. And then what really sold us was the analytics piece. We had no line of sight to data to drive any sort of quality initiatives. And so on a routine basis, our two teams get together and review our analytics, and that's what we've done to drive process and performance improvement since the beginning.
Yeah. And maybe since we're talking about the analytics piece, how have you used that? So I know members of your team and our team get together and we go over to treatments, et cetera. How have you utilized those analytics to further improve your program?
Sure. So we didn't know what we didn't know. Like I said, we were completely blind to that. We were very pleased to see the dramatic increase in treatment completion rates. Something we did not anticipate is our opportunity from order to treatment time. So on that dashboard, when we saw our results, they weren't terrible, but we felt like we could do better. And so we created an internal committee to really deep dive and figure out what are the barriers to speeding that up. Now that we had a common core reliable team, we knew what our response rate expectations were. And so the team was clocking in after hours within 30 minutes. And so we were just curious about that. And it really came down to those patients that didn't have any access. So the team was here and ready to provide a treatment, but they didn't have that line. And so that launched an entire process improvement effort around line access. And it actually drove our vascular access team to being able to place those temporary lines. And we've actually seen a tremendous improvement in order to treatment time as a result.
No, fantastic. No, it's great to see. It's one thing to get the information, right? The second is to have it be actionable and be able to do something that you can see tangibly is changing your care model. Well, maybe if we can just take a step back. So you've made this decision and you said you had this 6-month timeline, and at 4 months you said, you know what, we're gonna make this happen now. We're not gonna wait the additional 2 months. How did you get, there's the nursing team, which sounds great. Sounds like they were really behind this, particularly the ICU nursing team. How about kind of the rest of the health system, right? You have your physicians that are rounding, you've got other departments, and I'm sure, as the COO or CNO, maybe at that time, you've got the CFO, the CEO. I mean, you've got a lot of people there that need to get aligned behind an idea. So maybe kind of how you guys met, and then or how you guys aligned on, yeah, we're not able to pull the trigger, we're going to do it early.
Sure. So backing way up, our business plan included our partnership early on. We said these are the number of treatments. We knew that that volume could be higher if we had the tools and equipment needed to do our jobs the right way. So that predicted volume is what we used to build that out. We took the capital process all the way through the organization, and we made sure that we had the nephrology medical staff buy-in. So the rest of the medical staff, you know, that sits on MEC was like, if nephrology is happy, like we're happy, right? Because that's their area of expertise. So we also pulled in early on the supply chain team, infection prevention, and HIT, because we had to rebuild order sets. We brought in the regulatory team. So we're a Joint Commission accredited facility. And so there are expectations that are dialysis specific to Joint Commission. And our two teams actually did a crosswalk exercise to make sure we had the policies, competencies, and procedures that would meet that. A little side note, for several surveys prior to this, we had Joint Commission findings. And this was the first survey that we did with the new setup, and we had 0. I mean, Joint Commission was thrilled with the product. So back to that business plan, we took it through lots of, I would say, building had to occur. Parallel tracks were going on with the staff training, because as you might imagine, we took inpatient nurses and made them procedural nurses. We had to set up 24/7 call and schedules, and then, you know, really have people willing to move and flex depending on what the volume was. We also set some parameters for hours of operations, the definitions of urgent and emergent cases. And we had those things in place when we finally decided we're going to go early. And then we've just constantly tweaked since then.
No, that's great. And then just a question. So, okay, new technology, new model of care, right? A lot of change, right? A lot of change management along the way.
Yeah.
I imagine. So any logistic challenges or technical challenges you incurred along the way, you know, either whether it was with the technology, with the workflow or patient flow, anything there, and maybe how you guys have addressed it?
So we had to change the bedside ICU clinical practice from a CRRT model to a PIRRT model. And that required the ICU team to receive special training. And so that was something that when we went live with this, 100% of the ICU was not done. It would have been if we would have stuck to our timeline, but that was a pain point for us because we had to make specific patient assignments accordingly. And so that wasn't, you know, as smooth as we would have liked it or planned for it to be. But we worked through that. You know, some other lessons learned were, you know, specific access needles and, you know, patient anatomy and how the vascular team fits into all of this. But I will tell you, there was such a sense of stress and relief, a stress removed and relief provided, that people were really bought in early on. And that made the changes that we needed to continue to make much easier.
Right. Great. Well, you had shared some data with us from your first year, which is really exciting. Before we jump into that, I just want to encourage anyone who is joining us in the webinar, quite a few of you there, please feel free to drop any questions into the question and answer section at the bottom of the webinar. Would love to address those as we continue. Oh, and just as I prompt one, here's one question. Any pushback, I'm assuming from either the staff, clinical staff, so physicians or nurses, in moving to the PIRRT model? Any issues you encountered there?
No, so our model prior to this was a one-on-one ICU nurse doing the CRRT practice. And it is the same way with the PIRRT process. And it wasn't, I would say, pushback. It was just a change. And as long as, you know, we provided the training, they were completely fine with that. How did we get the nephrologists to agree to Tablo? They were the ones calling me about all of the issues from that contracted service. So they were pretty much to the point where we will do whatever you tell us. We will do anything different, but I can't get what I need from my patients. And so for them, yes, they looked at the machine, but when they looked at those 6 nurses that they already knew, they had a trust level, a rapport, and a comfort with them that just made them feel so much better. And so those are the only 6 people that call them. Before, it was kind of a rotating door with that contracted service, and they never really knew who was on the other end of the phone. And so they have complete trust and faith in those 6. And as you might imagine, you know, that's a great bi-directional relationship that was formed there.
Absolutely. And have you heard that same kind of comment from patients, you know, that then they come, they know they know who their staff is going to be, they, you know, if they do get admitted?
Yeah, that's something we did not anticipate. As you might imagine, some of these patients are challenging to manage, and so they frequent the health system. And so the nurses have gotten to really know these patients. The patients have gotten to know these nurses. They're talking weddings and baby showers and, you know, just life events. This team wrote a grant request for some entertainment in that dialysis unit because they're there for several hours. And it's fun to watch them have, you know, a targeted intervention that's meaningful to them. So those nurses know when there's a certain patient that he likes to watch a certain old Western show and it's teed up and ready to go, you know, and it just takes your patient experience to a whole new level.
Yeah, we talk a lot in healthcare about personalization of care, and we think about prescribing medications or therapies specific to one person. But here you're dealing with the other part of personalization, right? Some of that mental, behavioral health kind of things, just feeling comfortable, even though you know you're in a health system environment and you have an acute illness. So no, that's great to hear. If we could. You had shared some data, so let me go and see if we can get those thrown up on the screen here. I would love for you to kind of talk through here. I mean, these are some really impressive results, and please, anyone ask questions. But Brittni, if you wouldn't mind running us through kind of some of the data here that you've shared with us.
Sure. So because of the Tablo analytics, we're able to get this. So we had to go back and do a manual count in each of these things so that we had a baseline to grow from. So just know that. I already touched on the volume increase. The treatment success rate. We never had thought about this. You know, before, if a patient didn't tolerate a treatment, they didn't tolerate it, and we brought them back, you know, to their room. But because of the analytics, we were able to see that stark increase. I mean, that was just kind of, you know, another icing on the cake. We're doing the right thing. We are making sure that the specific patient is getting the specific treatment they need at the right time. And that's powerful. In terms of central line bloodstream infections, we had a huge reduction amongst patients that had dialysis lines. And we attribute that to there are 6 people that are cleaning, accessing, maintaining these lines and these dressings. There was no way for us to have oversight in the clinical quality of the previous vendor. And so that's huge in and of itself. And the CLABSI penalties are not even built into our ROI. Our ROI is built on volume alone. So that's additional cost savings. And then our treatment time to, I'm sorry, the order to treatment time is what this next item is, 2.5 hours. And let me touch on that for a little bit. We didn't anticipate the patient flow gains that this department and operation would result in. And the way we were able to drive that down, for example, is when patients present to the ED and they don't need to be admitted. They just need a treatment. We're able to pull them out of the ED, provide that treatment in the dialysis unit, and then discharge them from there. And because of that, we're able to decrease the order to treatment time, and we are also able to facilitate patient flow and keep the ED clear. Additionally,
and maybe, oh, sorry, Brittni, maybe just touch on kind of how that, how that was different, right, with an outsourced provider. Like how challenging was it to do that kind of process with a different technology and an outsourced provider?
It wasn't just challenging, it didn't exist. The patients would be admitted and you would wait. And then when we started that ED process, we got to thinking, okay, that's on the front end of patient flow. What about on the back end when we have discharge orders pending a treatment? We're able to pull that patient into the unit, provide their treatment, and discharge them home from there. Meanwhile, that bed is being cleaned and turned for another patient. And I really believe it's because we have ICU nurses that have that patient flow mindset that they're like, oh yeah, I know how to discharge patients. I know how to admit patients. And those were, just things we didn't anticipate that just added to the outcome of what we did. And then I already told you about the 100% staff retainment. But
right, which is fantastic. Yeah,
I might add this. So, this volume increase seems huge, and it is, but we have not added a single FTE. Because of our efficiency, we're able to fill up the dialysis unit. And because we had strict parameters in place for after hours urgent and emergent cases, we've been able to absorb this. What we did do is we handed off the supply chain ordering process and piece to that department. But that didn't result in an FTE increase either. They were able to work that into their daily operation. So just a little nugget of an additional benefit.
No, that's great. And maybe could you talk about a little bit, obviously a 280% increase is probably not what most people are anticipating when they insource a program. So what do you think are maybe some of the drivers of that? I mean, is it massive population growth in the Norman area? Is it, kind of, what do you think is attributing that growth?
I think that we now have a reliable service. I think that the physicians are ordering appropriate things. I think that the patients are happy and they're coming back to the organization. I think that those patients that may be non-compliant in the outpatient setting know where they can come and receive care. Not that that's what we want, but I think it's a multitude of things. And then I also know that we've almost eliminated any transfers to other facilities because of a dialysis reason.
I see. So maybe some patient preference, maybe a physician, or knowledge that they're going to get good care at your facility, and then the ability to care for your entire population.
Yep.
Yeah. There were a couple questions here in the chat, so maybe just shift here.
Yes.
So one, do any of your ICU trained nurses that are now doing dialysis, any of them still working in the ICU? Maybe talk through how you're doing that with your staffing.
Sure. So we did offer all of them to be able to keep secondary positions in the ICU if needed, and they're allowed to do that. I will say that yet again, one of the additional benefits is should you have a patient decompensate in the dialysis unit, or God forbid you have to run a code, these nurses are competent and comfortable doing that. Whereas before, they push the button and wait for the resources to arrive. So that's been very beneficial.
Great. And there were a couple questions here. Maybe you can just talk through the process about patients in the ED that just need dialysis and your ability to kind of move them to the unit and then discharge. A couple questions on whether that's outpatient dialysis, or how are you kind of coding or managing that so that you can move them quickly through that process.
Sure. So that is listed and it's coded as an emergency treatment. So they can't wait for an outpatient chair. They need to be done. And that's how we're handling that.
Okay. Great. All right. And then if we can move the slide down and we can, there we go. Just feel like I could hardly see you anymore. And then you had talked about, kind of a very thorough ROI ahead of time, right? And
Yeah.
really looking at all the different costs and things that go into this and when you anticipated that you may be able to see that return. If you can share maybe kind of how has that gone? We're a year in, so how are we doing? Are we at pace? Are we behind pace? Kind of how has that ROI actually played out?
Sure. So we thought that our ROI would take about 2 years based off of the previous volume. And we have actually paid for the capital within the first 3 months. We really had no idea it would happen as fast as it did. I see the question here about the timeline for the transition plan. I can tell you that we started planning this, and our fiscal year starts in July, by the way. We presented our business plan and ROI to the capital committee, got approved by the executive team and the board in the month of July. So by the end of July, that purchase order was placed. The equipment arrived about 6 to 8 weeks later, and we kept it here for setup, clinical equipment approval, and then, got it placed so that we could do some workflow scenarios and testing and training on all of that. And so we pulled that trigger really in January and hadn't planned to do that until about the end of March, beginning of April.
Great. I think there's a couple more in here. I wanted to ask one more question here, and I'm sure it's probably what a lot of people listening are interested in too, would be, okay, you went through this process, right? You made this decision. You pulled the trigger early.
Yeah.
I'm sure there was plenty of learnings along the way. What are some lessons learned or some things that you learned through this process that, if you were to go do this again, or that you would advise another health system that's considering moving to this insource model with Tablo, kind of what are some lessons learned and some advice you could potentially give others as they look to do this?
I would recommend, and we are happy to share this, if anybody wants to do this, if you could get some examples of policies, procedures, and order sets from other organizations, do that. We did that. We went for a site visit, very helpful, because that was one of the pieces that made our team the most anxious. We knew that there was always accreditation findings, and we wanted to make sure that all of that paperwork was in place. We didn't realize this in the beginning, but if you have the opportunity to build this team collectively together, there is so much cultural power in doing that. Instead of adding, one person per month, we pulled everybody together at one time ahead of the go live, and they have just had an amazing team effort and response. So I didn't expect that cultural element, but that team is very, very strong. How many tab machines did we purchase? So we purchased 12. And that was based off of us collaboratively working on the volume. We probably need, honestly, about 10 out of that 12, but the additional 2 give us the ability to have them maintenance if need be. We haven't had any of the machines, go down for any period of time, but it gives us the opportunity to have things placed and ready if we want to clean anything while the others are in use and not wait till the end of the day. And there's a question here about how is our emergent dialysis different from our inpatient programs that you already have. And really, it isn't much different, I would say, other than we never had the patient flow opportunities that we had before this dedicated team. So how many treatments per month? We're up to about 200 a month.
Apologies, my internet provider apparently did not want me to continue this webinar, so
You're
sorry.
just flying through that. the question and answer section. So I think I've got them all caught up here.
Right. Well, we do have some time for any more. Oh, there's a quick question there, Brittany, on apheresis.
Apheresis. We don't, I'm trying to think of, the Tablo device doesn't do that.
No.
Yeah,
So this would be
yeah.
plasma exchange, plasmapheresis,
Yeah,
apheresis,
yeah.
those type of.
Yeah, no, we do not.
Right. Other questions? Anything else, Brittany, that you want to share or you've been asked in the past? I know you've talked to several folks in the past from other facilities. Anything you've heard or questions that maybe you could share with the group?
I think we've done a handful of show sites where we invite people to come in and see it in action. And every time, the feedback that we have received is that it's been really good to see the operation happen in real life. And so if you have that opportunity, I would suggest taking the time to do it, because it sounds like a lot of work, and it is initially. Those first 6 months, yes, but now it is on autopilot, and we've moved on to other initiatives. And so it's just time well spent. The patient satisfaction and the outcomes just speak for themselves.
Oh, that's great. I did see one other question here in the chat about are you doing SLED? So I guess those longer treatments in the ICU.
Yeah, we are. That doesn't seem to be nearly as big of a deal as it used to be. Mainly because we've got backup resources with the dialysis team, should we have more than one patient going on it at a time, kind of a thing.
And you're staffing those longer treatments in the ICU, those SLED or PIRRT treatments. You're staffing those with your ICU nurse at bedside.
Correct. Right. Yes.
Okay. All right.
Yeah, there was a question here about done differently before go live, what we know now. Trying to think if there's anything differently we would have done. I don't think so. I would highly recommend that you do the on-site actual demonstration training. After we went live, we did end up partnering with our clinical education team to get an access mannequin. And that was really helpful to help the team be more comfortable. So if you have the opportunity to do that up front, that may be a suggestion.
Yeah, I did see one other question here about kind of where do you go now? Where any thoughts or plans for your program now, either expanding in-house operations or expanding your program, potentially going outpatient? Kind of what are you thinking now?
Yeah.
Is in the future for Norman Regional?
That's just it. Where we go now, we definitely have our eyes set on accrediting this service. We would really like, somebody external to come in and, audit us and challenge us. And so we like to do that with each of our key service lines. And then, yes, we are having the conversations about outpatient. I mean, I can't help but think about the patient flow opportunities if we had the ability to schedule our own chair times and just extend that relationship to the outpatient space. We feel very comfortable with the machines now, and it's the same physician group outpatient is in. So there is some synergy there.
Yeah, and I think that one of those questions I think was for me around kind of how is Norman Regional different from other Tablo acute programs. And I would say one of the things, and this is why I think it's so valuable to have, different folks on to describe how they're handling, the in-source model, is obviously staffing in a world where there is a nursing shortage, a nephrology nursing shortage, right? How are different health systems addressing, those challenges, whether it's hiring from in the area? And I thought, to me, your approach in taking critical thinkers that are used to managing complex patients and used to managing lines and understand those things, having that alignment with your nursing team and having their desire to improve quality across the health system and say, we will do this. I think that model of, if there's a health system who's worried about where they're going to hire or how they're going to hire, right. What we've seen is, in general, people have not had trouble sourcing those nurses. It's kind of that initial question, and then you have the reality, which you are able to find that nursing staff. But to me, your ability to do that on an internal basis and develop them, and obviously produce very high quality dialysis based on your CLABSI rates and their ability to scale to almost a 300% growth. And I think your retention rate, obviously, this was something that they've, they value their job responsibilities and high job satisfaction to stay in an environment where nurses can very easily move from facility to facility, and often do. So, so to the person who asked the question about how does this differ, I don't know that it's different. It's just, to me, a way that this particular health system addressed their nursing, and then our ability to work together from an analytics standpoint to help continue drive quality improvement. And I think this team has shown itself to be very driven in providing the best care they can, and it's been exciting to partner together and deal with and deal with the challenges and see how much better can we get. And so so I think that's not a difference, but just a unique way that Norman Regional handled it.
Mm-hmm.
Let's see. There's another, the adoption timeline. I'll say in general, that 6-month timeline is pretty typical. It is usually, I'm sure, Brittni, working with our team, you probably have that timeline and set, and that is a pretty typical timeline. However, we have seen these types of things happen before. Either the outsourced provider, may exit early, or in your case, kind of that urgency within your health system. And so that ability to do it sooner if we need to, but we usually do like to, think through that 6-month timeline, but we've definitely done implementations in shorter time. We're here to work with you guys. And so we'll partner with you in whatever the needs are.
And this staffing statement here about having 1 full-time, 1 part-time, and 3 PRN to cover 24/7. Yeah, that is challenging. And what I might suggest is there an opportunity to create a dialysis call group from lots of different departments internally? So maybe that's ICU, maybe that's ED, maybe that's the house supervisor, resource nurse team. And then, you might even look in the procedural areas, OR, cath lab. These days it is harder and harder to find clinicians that want to take additional call. I get that. And so I don't know that I have a solution for that. Yeah, you're currently cross-training. That would be my recommendation. But, on the flip side, if you have that volume increase, then you should have additional revenue to justify, FTE expense beyond what you have today. So that might work for you. Which year did we start this? So we just finished the 1-year mark this last February. So we went live in 2024.
All right. And one kind of last call for questions here, coming up here on about the 45-minute mark. Any other questions there from the group? All right. I see no more questions in the queue. Brittni, thank you so much. Always great talking to you. Thank you for being willing to share kind of your story and even helping troubleshoot some of these questions here for some of these other facilities. It's been great to partner with you. Thank you for sharing everything you guys have done there, and wish you much more success going forward.
Thank you. And good luck to everyone. If I can be of any further assistance, please let me know. Happy to help.
Thanks.
Thank you.